My name is Bhatt. I am a cardiologist at the Massachusetts General Hospital, and I'm an associate professor at the Harvard Medical School. And today, I wanted to share with you the story of how I learned that the best way for me to start taking better care of my patients is to see them less. So my journey to this revelation started about 10 years ago. I take care of adults with congenital heart disease. So these are individuals who were born with holes in their heart, valve disease. They were born a blue baby. And they then go on to need lifelong care. And in our pediatric training, in fact, the pediatrician you saw earlier on rounds trained with me, in our pediatric training, we would see these patients come in. They would get imaging studies, they would go home. They would come in for a visit in the clinic, they would get a stress test, they would see the surgeon, and then the next year they would do all of this again. And when I graduated, I said, I want to see the ones who are age 18 and older. And the reason was we did so well in pediatrics that we now had more adults living with congenital heart disease in this country than we do children. But we didn't have enough doctors to serve those 1.5 million adults. So I started my practice. And when I started my practice, the patients would come in and they would meet me, and it would be great, and then they'd go home, and some would come back, and some just wouldn't. And then others would be with their pediatric cardiologist, but we had a transition program. When you turn 18, you come to the adult side. And some of them would come to the adult side, and some just wouldn't show up again. And then there were the patients who would come and see me in the office, but they would say, I skipped the test. Sorry, doc. And so after about a year of this happening, I decided I kind of needed to figure out why this was happening, because it didn't seem right. And so at that time, I said, what any good Harvard graduate does, let me go to the literature, because that is where we learn things. And actually, the literature was helpful this time. So as I went there, I learned that there was a phenomenon called loss to follow-up. And it turns out that in individuals who have chronic disease, there is a pretty good likelihood, especially in the cardiac population, that after age 18, 50% of them will not come back to care for somewhere between 3 and 10 years. They just won't. So I joined some researchers and we tried to figure out why. And one thing we learned was that neither the children nor the parents understood that they needed lifelong care. We hadn't explained it to them adequately in childhood. The second thing we did was actually a logistic thing. We looked at the zip codes of the patients who were coming to see me, and we learned that many of them come from very far away, rural areas, and that others who were close by came from low socioeconomic status areas. And for that entire group, transportation to come and see us, child care during that time, being able to leave work for multiple imaging appointments and testing appointments, that was a huge barrier to care. So we got together with a group of cardiologists from New England, and we built materials to teach people about chronic disease care. And I gathered my group and I said, can we do CAT scans and MRIs and stress tests and surgical visits on these patients all in the same day? And everybody agreed. And we started doing all our testing in one day. So patients would just come in one time, they would get all their testing done, and they could go home. Only one day that they were spending away from their families. And things got better. We saw the patients more. Things were improving, except that it wasn't perfect, because the emergency room doctors throughout the Commonwealth of Massachusetts were calling me saying, hey, your patients here in our emergency room, they say they don't really know what kind of health care they need. A quick pro tip for those who want it. If there are emergency room doctors, multiple of them, who have your name on their favorites list on their iPhone, there is probably a systematic issue in your practice that you need to address. So we went back to the patients. And I actually had a trainee who went and met with every single new patient who came and met with me. And her research was to figure out, what are they understanding from their visit with us? Where are we going wrong? What are they understanding? And what we learned is that these patients were all of them, fast rather than slow thinking. They were grabbing at words. They had adrenaline flying. They were trying to understand, but they could not grasp the complexity of why they needed chronic disease care. Now, if you ask my friends, they'll tell you that makes complete sense, because it takes as long to get from Maine to Boston as it does to get off the exit in Boston and up to the hospital, right? And then you have to get up through the hospital, which is like a small town. And then you still have to meet 3 more people before you get to me, the doctor. So by this point, you're definitely fast thinking, sitting in that room with those very nice colored walls in the blue gown. The other thing we learned, the doctors, the physicians were also fast thinking. It turned out that we didn't have the capacity when we were running from one room to the next, answering the nurse's question about a refill and an urgent issue, teaching the student and the fellow. We didn't have the capacity to be able to slow down. So we walked in the room fast thinking, they walked in fast thinking, and then we were trying to build a bond and a relationship and make sure we did good medical care. Breathe. For the first 4 years of my career, I took care of some of the sickest cardiovascularly diseased individuals who were young with all of this noise, not that noise, that's a good one, all of this noise in the background, and I was exhausted. And so were my patients. So I took a group of them who actually were right around the same age as me, and we all decided to sit together. And I said, guys, what am I doing wrong? Because I was a new young MD, and of course this was me, I was the problem. And that was the first time I started to hear these phrases. We are waiting for the other shoe to drop. Doc, I'm not generally anxious, but the week I'm supposed to see you, I can't even function that week. Health-related anxiety. Hey, Doc, we have so much going on in our family right now that just one more thing is going to break us. And so I don't want to know, so I'm not going to come in. This was purposeful denial. And that was when I realized that I needed a single solution. I needed a solution that would allow me to bond with my patients in a longitudinal relationship, but at the same time, be convenient for them, be non-threatening, and be far less stressful for me. Serendipity. In the middle of all of this, the Massachusetts General Hospital had a telemedicine program that had gone well enough in psychiatry and in stroke care that they were going to now open up to other divisions. I was first in line. And we started to use telemedicine. We started to use it for 2 very specific reasons. Those patients that we had coming in, getting all their testing in one day, there was no way that in 30 minutes, 22 minutes, I was going to be able to explain to them everything they needed to know. And so we started something called virtual visits. It was doctor Skype. I was in my office. They would be at home on their laptop. We would be able to see each other and talk. We could do this as often as we needed after that initial appointment. And I could even turn around my desktop and share it with those patients and show them what was happening on that screen. The second population for whom we used this, however, were the patients who said, I'm not coming in. These were individuals who said, Doc, it's great that you have so much expertise, but I'll take my chances. So, it's interesting, actually. You know the phrase, necessity is the mother of invention, right? So I like to think that in this healthcare world right now, the phrase that most applies to me, desperation is the mother of adoption. I needed telemedicine. I need to get my patients back. And so I was on board. Now, I was on board, but I wasn't ready to oversell, right? Because I'm a physician. The social norms tell me that the laying on of hands is what I am supposed to do. And telemedicine will never let me lay my hands on the patient, so it's a limited tool. So I could maybe use it for a few of these things, but I wasn't going to expand this because this wasn't about who I was. I wasn't about technology. I was about the patient. Until I met John. John had an ultrasound, and I knew after John's ultrasound that he needed a valve surgery. This would have been his 3rd open heart surgery. John was 30 years old. John was sitting on the couch at home. His partner was sitting next to him. Dog was off in the side room, as they usually are. And I just need to communicate enough with John to let him know that he had to come in and see me, that this was a bigger deal. Because then he would come in and see me, and I would hold his hand and sit with him and tell him that it was time for the third surgery. That's all I needed to happen. But John was persistent. He was probing. He was asking questions. At one point, he asked me, "Can you show me the old ultrasound and the new one side by side?" And I thought to myself, no, I can't do that, because then you'll see the valve has degenerated and you'll know that you need surgery, and this is not how I'm going to tell you. But against my better judgment, because he kept pushing, I looked up at the camera directly at him. The camera's perched on top of my screen. And I told him, "John, it's time. You need your third open heart surgery because we have to replace this valve." And John put his face down in his hands, and his partner put his arm around his shoulders, and John's whole body heaved for what seemed interminable, but was probably less than a minute. And then he looked up, and he looked directly at me. And with tears streaming down his face, he said, "Thank you. I didn't think that you would tell me today." I must have looked confused because his partner jumped in. "Doc, we needed you to tell us today when we were here together. The last time John got this news, he had to drive home from the city 3.5 hours by himself until he got to me." And then John chimed in. He said, "Doc, did you know the smell of the hospital is different when you leave a clinic visit knowing you need another surgery? It's just different." They knew. They knew they needed a valve surgery. He knew how he was feeling. They knew it was time. They weren't afraid of that coming into the virtual visit with me. They were afraid of the likelihood that because of the tradition of medicine, because of my assumptions of what it means to be a doctor, that I might not tell them what they needed to know at the time they needed to know it over telemedicine. A few months later, I'm happy to say, our telemedicine practice grew exponentially. We just skyrocketed. And some people said it was because of the advertising and the marketing, and other people said, oh, it's the technology and it's the platform that we chose. And a few people actually said, oh no, it's because you go out there and you do lectures, which I do to this day, on patient and provider adoption, right? I knew that wasn't true. It was because I, the cardiology champion of telemedicine, finally understood. Telemedicine was not the single solution for my healthcare problem. Telemedicine was not a replacement for seeing the patient in the office. It was actually a brilliant vehicle through which I could connect with my patients in addition to everything else that I was as a doctor. And it took me understanding that for the patients to want to do this with me. They wanted the whole me. They wanted all of Dr. Bhatt. But because of what I assumed about telemedicine, I was giving them a very limited version. For this, I was the limitation in telemedicine. There was nothing about the technology that was limiting us. Now, interestingly, at right around the same time that this was happening, I happened to get an article published in the Journal of the American Medical Association. Happened to is not true, actually. I was burnt out. Right? I was burnt out. I was driving home from an event at my daughter's school in the rain, and I thought to myself, I need to write this out. Writing is my therapy. I need to write this out. I need to share this. I had learned to share my whole self with my patients, but I was not sharing my whole self with my colleagues or my trainees. What I was sharing was the perfect, this is Dr. Bhatt and everything is going great. And there was all this depth underneath it that nobody knew about. I'd like to share with you an excerpt from that. For many physicians, most of their waking hours are spent interacting with patients. To say that practicing effective, empathic outpatient medicine 5 days a week is demanding would be an understatement. That is perhaps more true in today's documentation-oriented world. Physician burnout is touted as the most powerful driver of individuals leaving the practice environment. Perhaps those who make it, who can practice for 40 years and still hear the calling, are the ones who spend time with the people, not the patients alone. The outpouring of response to this was immense. I got letters from all over the globe of people who said, "I see you. I can relate to this." It's interesting, actually. Physician burnout was just becoming a thing then. The word well-being wasn't part of it, right? It was just physician burnout at that point. We recognized that if there was a clinician who was overworked and under-supported, we were seeing two major things happening. There was an increase in physician suicide rates, and there was a decrease in patient safety happening at this time. And then we also saw the relationship. We saw that when you had physicians who were less engaged, you had patients who had a worse experience. I want to show you two of the people who wrote back. These 2 pages lit up my day. They explained why I am still happy practicing medicine after well over 50 years. Care of patients does as much for me as it may do for them. The other person wrote, "Although you are much younger than I, you are absolutely right. In my 40 years as a family physician doing obstetrics, it is the stories shared by my patients which stoke the passion. Don't ever let that change." For all these people, they knew that it was the relationship with the patients that made them able to give the kind of care they needed to give over a lifetime. You know, it's actually funny. There are these phrases you guys have probably heard, right? Physician-centric versus patient-centric care. Does that sound familiar, right? I don't know when that dichotomy happened. Because if you ask any of these people who wrote to me, if you ask me, we will all tell you that the doctor-patient relationship is one journey. It is one journey that we get to take together. That is the privilege of that relationship. And so there should not be a dichotomy between the caregivers and the patients. We are on the same journey. It was telemedicine that really brought me back to that journey. It was telemedicine that brought me back to these relationships. We now use digital stethoscopes in the community, in the rural areas, to make sure those people are getting tertiary care. We now have virtual resiliency sessions, group sessions online, where we talk about health-related anxiety and how to treat that. We now have Bluetooth blood pressure cuffs for our pregnant women at home, so they don't have to come in to get their blood pressure checked every week, but we can protect them from hypertensive-related diseases which lead to all of that maternal mortality. And so telemedicine actually took me from the institution of medicine back to the patient journey, and that is where I intended to start 10 years ago. Just took me a little while to find my way there. I want to share one more excerpt. I don't know this person. Dear Ami, I read your piece in JAMA as soon as I returned from the free clinic today. As a family physician, I delivered the babies, did their kindergarten, sports, and college physicals, and shared their family's successes and losses. That's why your essay touched my soul. I once found this poem by Kipling, which still speaks to me as much as it does to your essay. I have eaten your bread and salt. I have drunk your water and wine. In deaths ye died, I have watched beside, and the lives ye led were mine. If this isn't the universe telling me something, I don't know what is. Actually, this is the universe going, oh, thank God she finally got it. But I started by telling you what I've learned. That the way to take better care of my patients is to see them less. Not exactly true. The way to take better care of my patients is to see them less but connect with them more, because that is saving me as well. Thank you.